So we'll start with Dr. Keole talking about proton therapy and radiation therapy.
Well, thanks. Full room. So if we have some slides, if we could cue those up, and maybe while we wait. Oh, thank you. And that was quick. First of all, how many people in the room have heard of the proton beam program at Mayo Clinic? Wow, a lot. Okay. How many people feel they know the difference between proton beam and X-ray therapy? A few people. Wow, good number. Okay. So for the rest of you, I'm going to this is going to be a very high level, we're at 35,000 feet overview, maybe even more like a satellite, of what the difference is. And I'll give you the punchline up front. If you take nothing else away from these next 5 minutes, remember one thing: protons stop. Can you say that? Stop. That's it. We're done. Okay. So these are what we call linear accelerators. Linear accelerators are just that. We make radiation. They don't come out of an intranuclear source like we used to with cobalt. We literally manufacture it on site. The linear accelerator means we send an electron in a vacuum tube in a line from one point to another point, and when it hits a high density target, radiation comes out. And so that really is the take-home point. That's the engine. And it's 6 MV energy, which you don't have to know, but so you'll see marketing like crazy, and this is a Varian Trilogy, this is an Electus Synergy, Siemens CT on Rails, Tomotherapy, Novalis. My favorite is the CyberKnife. I hear the word cyber and knife together. It's a verb, it's a noun, it's everywhere. And I even want to get cancer so I can be treated with this thing. The marketing is that good. And then we have the Vero and we have the Varian TrueBeam. All of these are the same. So when I drove up here today, I drove in my family truckster, the Sienna minivan, and it's got a 6-cylinder, and if I'm driving up north Scottsdale this time of year around Barrett-Jackson season, I might come up next to a Lamborghini. I'm not going to try to take it off the line. Now, if somebody replaced the 12-cylinder Lamborghini engine with my 6-cylinder Toyota engine, guess what? We'd run more or less the same. These are all good machines, but the take-home point is none of these are fundamentally different than the other machine, despite what the marketing says, because it's all 6 MV X-rays coming out. That's the take-home point. These are cobalt units. This is a gamma knife unit, which is only used for brain lesions, and this is a cobalt unit, which is an MRI in it, but again, it's the same spectrum of energy. So that's the take-home point. They're all X-rays. So what is an X-ray? And most of you have probably had a chest X-ray at this point in your time, in your life. And if you think about it, once Dr. Gray, Dr. Bryce, or myself, we used to write a script for a PA and lateral X-ray in about 2 minutes. Now in about 20 seconds. Now we spend 5 minutes in the electronic medical record to do the same thing, but that's a different issue. You stand up against an X-ray panel, right? It's cold in that room always. We turn the temperature down on purpose. You stand with your chest up against an X-ray panel. The X-ray tube is behind you 300 centimeters. The X-ray tube fires. It comes this way. It goes in your back, out your front. That's why we call it a posterior to anterior X-ray, PA X-ray. And we get this guy. And in an X-ray, lungs are black, ribs are white, but basically X-rays come in one side and go out the other. The only difference between X-rays for diagnostic, like a CT or an X-ray, or a therapeutic X-ray from a linear accelerator is it's just a higher energy that we use to kill cancer. Same principle. Radiation comes in one side, goes out the other. And protons are different. What is a proton? All it is, it's the H of H2O. It's the water. It's right in your glass. Take that hydrogen out. It's got a positive charge. Remember, it's small. It's light. That's not the right physics term. It's got a low mass. On the atomic chart, it's all the way to the left and up top. We can accelerate it and we can steer it. It's like a car with gas in it. And then When the car runs out of gas, it stops. And this is a car with 70 mass electron volts of gas in it, and when it runs out of gas at 4 centimeters, it stops. This is one with 229 mass electron volts of gas in it. When it runs out of energy at 32 centimeters, it stops. And we can go anywhere in between. So the point is, this is more directed, and it can stop on a dime. So we can reduce the dose. So this is, so if you take nothing else, proton stop. I think this is one of my final slides. This is a young girl with a germinoma. That's a pineal tumor. Same thing Lance Armstrong had, except it happened up in the brain where actually X marks the spot. We can actually cure this almost 100% of the time, but we give something called craniospinal irradiation. We treat the contents of the brain, and we also treat the contents of the spinal cord. We're not trying to treat, anywhere you see color is radiation, by the way. We're not trying to treat the heart, the kidneys, the stomach, the ovaries, the bladder. None of those things are things we're trying to treat. But with X-ray therapy, we treat with a posterior beam. The radiation actually exits out the front of the patient. We check these patients by seeing, is there a red stripe on their chest, because about 65% of the dose exits out the front. With protons, we can stop the dose literally just millimeters in front of the spinal cord. We decrease the dose to the heart by 99%, the bladder by 99%, the ovaries by 99%, you name it. And does this stuff actually work? So what are you looking at here? This is that dose distribution of us stopping the dose in the middle of the vertebral body. You see these white changes, and there's gray in here? This white is actually fatty signal change. It's radiation damage. But the point of this slide is, this radiation damage matches up exactly where we said we were going to stop the radiation beam. So it's not just a theory. This is an MRI done 6 months after the treatment. This stuff actually works. It stops exactly where we want it to stop. So with that, do we just want to hold questions till the end? Or? Yeah. Okay.
All right, so I'll just mention a couple of themes as far as the future of cancer surgery. What I hope is we'll spur some ideas, and then we'll be able to take some questions on that. So one of the key aspects that we will have in surgery, that we have in surgery now and will have in the coming years, is integrating therapies. It's putting treatments together with surgery to make it more effective or less difficult for patients to go through. So intraoperative radiation, the types of things that you were just hearing from Dr. Keole, integrating that with our operations can make some of our treatments more effective. This is a picture of us delivering intraoperative radiation to a patient with a retroperitoneal sarcoma, where we've shown that integrating these therapies together has decreased the recurrence rate in this disease from about 50% to 11% among our patients. In that same theme is doing more treatments before surgery. This has been done for a while, but is an increasing way for us to be more effective with cure rates, yes, but also to have patients have less surgery. So this is a picture of a patient who on the left has a tumor in her breast, and this is before she began her preoperative chemotherapy, and then afterwards, right before we did surgery, that tumor, you can see, is gone. And in fact, when we did the surgery, 100% of those cancer cells were dead. So the question my patients ask in that situation is, well, then why did I have the surgery? And I think it's an outstanding question, and that's a place that we hope to go in the next few years. The reason we do the surgery now is because we can't be sure who has 100% cell death of those cancer cells. But we're actively working on ways, measuring tumor DNA in the bloodstream and other ways, to be able to decide, when can I be put out of business? When can we cure these patients and be secure about it so they don't have to go to surgery at all? Some other integrative therapies. Dr. Bryce is an expert at giving things, and Dr. Anderson, who you heard from, giving therapies that will treat the patient's whole body with chemotherapies and immune therapies and so forth. We can, with surgery, target just one area of the body. So this is a patient who had spread of melanoma all over his arm, but we were able to take him to surgery, put catheters into the arteries and veins leading into that arm, and give therapy just to his arm and spare the rest of his body. And this is him about 8 weeks later with all of that gone. Some other things in reducing the problems associated with surgery is we now know even after the surgery we can rely on some other treatments. So there are trials now that have demonstrated, for example, in certain patients' situations, if they're having planned radiation and other therapies from my colleagues that are seated to my right after their surgery, we can do less surgery. This is a photograph of a woman suffering from lymphedema after breast cancer surgery. We now do many fewer removals of all of the lymph nodes from these patients because we know it is safe in certain circumstances to rely on those other therapies. So decreasing the amount of surgery, again, is a theme. We ended up somewhere else. Hang on. Let's see if we can get back to where we were. I keep getting back to Dr. Keole's slides, so we'll maybe stop there and maybe we can find Dr. Bryce's slides. The other themes that I was going to mention is less invasive surgery. So there's an expansion of robotics so that we're able to operate in smaller spaces in places that we weren't able to do through small incisions previously by using robotics. There we go. And tissue engineering and 3D printing is an increasing area in surgical planning and in being able to execute things. So tissue engineering and things like tracheal transplantation. So when a patient has cancer, has to remove their trachea rather than spending the rest of their life without being able to breathe through their mouth, can have tissue engineered to do tracheal transplantation. So less invasive surgery, combining therapies, tissue engineering, 3D printing, all are on the cusp of being used more and more in cancer surgery. Thanks.
All right. Thanks, Rick. Maybe we'll go ahead and throw this slide up. This is Dr. Gray's last slide. It's kind of worth seeing. This is what he's talking about with a engineered trachea. So this is a member of our staff who's working on growing these trachea, basically building them artificially in the lab and hopefully being able to eventually transplant these into patients as a way of making the treatment less morbid. All right. Did that get up on the screen? I can see it here. Okay, good. All right, so what I'm going to talk about is where I think medical oncology is going, hematology oncology. So talking about the medicinal approach, whether it be IV medicines or pills, also talking about immunotherapy, as we heard about from Dr. Anderson a bit earlier, and also talking about detection. So ultimately, there's a number of goals that we're always chasing in parallel. Better outcomes overall, as defined by longer life, as defined by higher cure rates, as defined by less toxicity, because of course we want to achieve higher quality of life for whatever time it is we can achieve. And we are committed to all of these goals. It's certainly not just about attacking the cancer. It is about thinking about the patient's life holistically, making sure that the time we can give is of good quality. And so we've heard this morning, I mean, we cannot talk about in a cancer conference anymore in advances without starting with immunotherapy. And you've heard this from Dr. Anderson this morning. Most of you have probably heard of President Carter, had metastatic melanoma with brain metastases. And here you had a 90-year-old man, tremendously frail. Frankly, 5 years ago, we said there's really not much we could have done for his melanoma. Chemotherapy would have been too much. It would have been too toxic. The treatment would have been fatal in a man of this age, of this general health. And yet, immunotherapy gave him a treatment option that in all likelihood has cured him. And that's saying a lot because we're talking about what was a very aggressive disease. It remains an aggressive disease, melanoma. But it also says a lot because we're talking about somebody who, who with his age, with his frailty, could not withstand anything too aggressive. So we want to cure people, but we want to cure people in a way that maintains their function. Better than cure, of course, would be prevention. Let's keep people from ever getting cancer in the first place. And so one aspect of immunotherapy that was touched on earlier was the idea of cancer vaccines as being preventative. There are some cancers that are caused by viruses. This is where things like Gardasil comes in, HPV, as we've known for many years, a driver of cervical cancer, but also now a growing list of other cancers being driven by HPV. I mean, this is a common virus, it's everywhere. And so giving an anti-HPV vaccine can lower cancer rates over the long run. Obviously, prevention being better than cure. You heard about manufacturing vaccines for the individual. And this is part of what Dr. Anderson was presenting. The ability to take a cancer out of a patient and then in the lab take that patient's immune cells and find a way to activate those cells specifically against the cancer and reinfuse activated immune cells back into the patient. There's a few different varieties by which this is done. For the most part, this is still very experimental. I mean, there's limited application in greater use today, but nevertheless, these studies are actively moving forward in a variety of malignancies. And there's tremendous hope here that if we can harness the patient's immune system in a wider variety of cancers, we will get away from the era of chemotherapy and of more toxic therapies. Better detection. Obviously, one of the big problems in cancer is finding it. You know something's wrong. Where is the tumor? So some of the prostate patients in the room may have heard about what Mayo's done with this technology called a choline PET. This was a type of scan that was really developed by one of our urology colleagues up in Rochester, and we will have here in Arizona very shortly. And what this does is it allows us to detect much smaller volumes of cancer than we previously could have. So this particular case, which has been out in the literature quite a bit, but this is an example of a patient up in Rochester, one of the early patients who had their initial treatment with radiation, but then the PSA was going up very rapidly. Everyone knew something was wrong, but all the traditional scans couldn't show us where the disease was. And the book answer to this scenario would have been that with what we were seeing in the PSA, this disease is disseminated, and therefore we really have to move on just with systemic therapies, hormonal therapies, whatnot. But they had this scan, and what the scan showed in this patient's case was that all the localizable disease, all the disease they could find, was located in the prostate. So they decided to go ahead and do a salvage surgery, which would be a very atypical treatment course. And in this case, the PSA hasn't come back up. And so precision of treatment with better detection, with more fine tools, can clearly lead to better outcomes if we can apply these widely, if the tools are strong enough. And so research into better detection, more precise tools is fundamental to better outcomes for our patients. And then cancer genomics, and we're going to talk about this more in a session in a couple hours here. You hear a lot about individualized medicine, individualized cancer care, testing cancers for their DNA to figure out what's wrong with that tumor and how might we approach it. Again, the concept here is to find more effective therapies, find less toxic therapies by approaching each patient's cancer as a unique entity, as opposed to the more traditional model of saying, we'll take 1,000 patients that look more or less the same, we'll treat them all, we'll see that a certain percentage respond, and that's the data we have, that's what we have to run with. Instead of looking at patients, 1,000 patients at a time, we're trying to look at patients one patient at a time. And this process also allows us to discover new targets. Inevitably, when you have to look at diseases with tools that make you think about disease 1,000 patients at a time or in large cohorts, what you end up finding is the common, and what you end up inevitably missing is the rare. But every patient is obviously unique. Every patient has, their own particular needs and, frankly, their own unique cancer. And it's those 1%, that tail of the curve that we've been missing for a long time. And so we think genomics really allows us then to approach those patients who have been neglected because they don't fall into the common. And then survivorship. And this is a very important topic in cancer, and you'll hear more about it in other parts of the session today. Cancer care doesn't stop after we stop treating the tumor. Survivorship entails many different things. Some of it is the social impact of the cancer diagnosis, some of it's psychological, some of it's the family, some of it's the long-term effects of the treatment, the toxicity from the treatment, the 50-year impact of having had chemotherapy for a pediatric patient, because it makes a difference. For example, if a child has chemotherapy for their leukemia when they're 5, their risk of heart disease when they're 50 is much higher. Of course, it takes a long time for us to recognize that. It takes many years of follow-up. So creating early intervention plans, monitoring, and then trying to reduce the amount of treatment we have to give early as we think about the long-term impacts of that treatment. So now we're going to open it up. We've got a few minutes left here. Hopefully take a few questions. Dr. Gray, Dr. Keole, myself, and we'll certainly be available throughout the day as well. Thank you. And there are some people walking around with microphones so that they'll hear your questions. Got a question here, there.
Dr. Samir, you put that stop sign on as a slide, and as a layman, we're led to believe that proton particle stops when it runs out of gas, as you said.
Correct.
Once it runs out of gas and it parks in the tumor, what happens?
Oh, that's, yeah, I didn't want to get into that much detail, but basically, at a broad level, think about, we use sparsely ionizing radiation. X-rays and protons at the end of the path are both sparsely ionizing radiation. It's kind of like the old adage, all roads lead to Rome, right? There was a central road in the middle of the country, well guarded. There was a road on the west side that was much tougher to get through, but once you got to the front gates of Rome, you were at Rome. So at the end of the path, basically you flick these secondary electrons and they do the DNA damage. And so that's what happens with both protons and X-rays. It's just that we have our interactions with the cells concentrated at the target area with protons, whereas with X-rays, they happen all along the path. That's the difference. Correct. Anywhere where the radiation goes, there's damage. It's equal, protons and X-rays. It's just that we're able to be much more efficient in concentrating the radiation deposition at the target with protons.
Question here, if I may. As I listened to all of this morning, cancer genomics, immunotherapy, advances in radiography, and all the rest, I'm asking myself, are we using chemotherapy less because of all this stuff? And are we headed to a world where chemotherapy becomes a relic of the past?
Yeah, so yes, we're using less because we're replacing it with other treatments. The tricky part about the question is the fact that chemotherapy it's a colloquial term, it's not actually a scientific term. So you can call a lot of things chemo, and we can argue about what, people do, about what constitutes chemo, what doesn't. At the end of the day, I would say that cancer, keep in mind, you hear it over and over, is many different diseases, right? So it's never going to be one solution for the broad spectrum of all that is cancer. But we needed lots of different tools. We need lots of different tools because of individualized medicine, because every cancer is different, because we need to have different ways to approach every patient. So do I foresee in the near future a time when chemotherapy is no longer useful? No, not in the near future. Do I think it'll be continually less? Yes. Will it be a relic at some point? Absolutely. I mean, I hope that the day comes where everything we talk about today is completely irrelevant, right? But that comes in fits and starts, and it's not going to happen in the next couple of years, I'll say. A number of questions on the other side here.
This side.
Good morning, docs. Thanks for being here this morning. I wanted to ask you, just as far as advocacy goes from a patient perspective, what could we do to advocate for being able to get proton therapy? There are obviously a lot of people in this room who are affected by cancer, and the insurance companies are not very willing to cover proton therapy specifically. I know that, Dr. Keole, you have been advocating with insurance companies, but as a group, as a large group of folks, what could we do to get that benefit?
Thanks. Thanks for coming. And yeah, as you know, this is, insurance companies, I try not to be cynical, but, their business model is obviously much different. They're obviously approach things from a much different angle than we do. I think for the biggest thing that I think is practical is we really need insurance companies. About 2/3 of the work they do is like a credit card company, meaning they manage benefits. So they actually charge the company that they manage benefits for 1.5% to 2%. And so really the company is the customer, and they're always right. And so to the extent that we can have big companies and the HR directors engaged, and from my perspective, we can get in front of the HR directors and explain to them and the senior leadership and why proton therapy, access to Mayo Clinic, and in my particular case, proton therapy is important for their employees, really helps us. And actually, we can make a very compelling case as to why Mayo Clinic not only provides great care, but also is a very effective from a cost standpoint, not just proton therapy, but really across the board. Thank you for the question.
All right.